Bleeding, chapter 25 of your book. Bleeding is bad. Stopping bleeding, controlling bleeding is good. What do we need to be concerned about with bleeding? First off, we need to recognize that some bleeding we have the ability to treat and control as EMTs and paramedics, and some bleeding, the best we can do is to treat it with diesel fuel or gasoline and the skinny pedal on the right. So not your brake pedal, but your accelerator pedal. That, like we talked about in trauma overview, trauma is a surgical disease. We need the right person, man or woman, with a knife to get in and fix the problem. We are not that person. However, our work is extremely important. We're going to talk about our contributions to keeping a patient alive and getting them to a trauma facility so that a surgeon or even an ER doc can get in and do something to treat the patient. Hand in hand with bleeding is recognition of shock and shock management. What is our major life threat with bleeding? It's death from hypovolemic shock, hemorrhagic shock leading to hypovolemic shock, then eventually irreversible shock. We're battling the grim reaper to try to keep our patients from sliding down that slippery slope into irreversible shock. That's sometimes we can't. Perfusion is key. Let's move down to this slide. Talk about the perfusion triangle. I don't have a board so that I can draw the old triangle for you. You can do it now. You can take a piece of paper there in the comfort of your palatial home and draw that triangle, and on one leg of that triangle write pump and the other write pipes and the other write fluid. So pump is the heart, pipes are the blood vessels, and blood is the fluid. Those three things working together, where we haven't suffered an injury and caused bleeding yet, those three things working together we call hemostasis. Stasis meaning staying the same or constant, hemo blood, so blood remaining constant, so it's staying in circulation, right? We're perfusing tissues, we're getting oxygen and nutrients out to the cells of the body and returning carbon dioxide and waste to be for the body to dispose of that waste and then bring in more oxygen, start the cycle over. Perfusion triangle is great as long as there's not a problem. So with bleeding, we're not talking primarily about a pump problem. We're talking about a fluid problem, but to get that fluid problem, we also have to have a pipe problem. So we'll talk about that. Somebody forgot to silence his phone. All right, here we go. Heart, we've spent considerable time with the heart over the course of the semester. The right side of the heart receives deoxygenated blood that's been returned into the inferior vena cava, superior vena cava, after the body has used the oxygen from that blood, returns to the right atrium, then into the right ventricle. out the pulmonary arteries, down into the arterioles, deep in those vascular beds within the alveoli. That's where the inspired oxygen makes its way down through the venules. The venules connect with the arterioles, and that's where diffusion takes place, and carbon dioxide is exchanged for oxygen because of the partial pressures of the gases, and then that oxygenated blood is returned to the left side of the heart, left atrium, down to the left ventricle, and then pumped out to the body through the largest vessel in the body, largest artery in the body, being the aorta, and then out to the body, and then the cycle continues. Nothing new there, right? Okay. Types of blood vessels, nothing new here. Arteries carry blood away from the heart. Why did that unoxygenated blood move from the right ventricle out to the lungs via an artery when arteries, we think, carry oxygenated blood? That's because the pulmonary arteries are carrying blood away from the heart, just happens to be unoxygenated this time. And then veins return blood to the heart from the tissues, so oxygenated blood is carried in the pulmonary veins back to the left side of the heart. Gas exchange that I just mentioned, that takes place out in the capillaries. Those capillaries are eventually one red blood cell wide, so those are extremely small. That blood files through. Oxygen is offloaded from the hemoglobin, and then carbon dioxide moves back into circulation along with waste, and then back to the lungs, or back to the right side of the heart. And that is through the process of diffusion. Blood, as you remember, I think we all probably learned this in 6th grade science, if not before. Red blood cells, white blood cells, platelets, plasma. Plasma is the vehicle carrying red blood cells, white blood cells, and platelets. Red blood cells carry oxygen, and as we mentioned, that oxygen attaches to hemoglobin, and that is the vehicle that transports oxygen to the tissues of the body. White blood cells have a major function in our immune system. And then platelets we'll talk about in a little bit. When we talk about the clotting cascade, platelets are there to plug the dam when there's a hole in the dam and we start bleeding. And blood clotting, as we'll see in a minute, also involves several different clotting factors, involves fibrin, fibrinogen, autonomic nervous system. We remember what that does. That's our fight or flight or rest and digest system. We don't have voluntary control over that. There are a few things we can do to slightly change maybe our heart rate, and we can voluntarily change the rate and depth of our respirations for a while, but overall the body has control of what happens with the autonomic nervous system. What's happened in the body is monitoring its needs, and the autonomic nervous system adjusts accordingly. How does it adjust? Let's think about back to one of the early chapters when we talked about uh, beta 1, beta 2, and alpha receptors. Those are all part of the feedback system for the autonomic nervous system. If you'll remember, uh, the body's rate of respiration is controlled in the medulla oblongata. When the chemoreceptors in the medulla sense a drop in pH in the body adjusts by increasing respiratory rate as well as the depth of respirations. If the baroreceptors, which are part of them are located in the carotid sinuses in the carotid arteries. If a drop in blood pressure is sensed there, that's going to trigger the adrenal glands to release adrenaline. Adrenaline has beta 1, beta 2, and alpha effects. So beta 1 effect, that's going to increase the heart rate, also increase the how hard the heart squeezes. So that would be the inotropic effect would be to make the heart muscle squeeze harder. Chronotropic effect, chronos like a watch or clock, that increases the rate. So that adjusts blood flow through increasing the rate and increasing how hard the heart muscle squeezes. So that increases blood flow, which in turn is going to adjust for that drop in pressure to help meet the needs of the body. We have tissues such as the brain and the heart that don't store oxygen and glucose and they need a constant supply of both. And this is part of how the body ensures that there is a constant supply of both. And then alpha effects, remember that has to do with contraction of the smooth muscle around the arteries, which decreases the lumen or the inner diameter of those tubular arteries. And when you decrease the diameter, you raise the pressure, and you also take peripheral circulation in the arms and legs and shunt, S-H-U-N-T, shunt that back to central circulation to perfuse the vital organs. Our arms and legs can wait a while our body is keeping the brain, heart, liver, kidneys alive. Without those, we cease to exist. Or, if you hadn't heard this in a while, results in a condition so that a doctor asks your family, do you have a funeral home preference? So we're trying to cheat the funeral homes out of business by being good clinicians. Okay, other thing, respiratory rate, as I mentioned, is increased, and also the adrenaline, the beta 2 effects causes bronchodilation. So we're trying to increase the amount of oxygenated air that makes its way down to the alveoli to get enough oxygen into circulation to perfuse those organs. Okay. Perfusion, what is it? Perfusion is providing oxygen and nutrients to the tissues of the body What is shock? If you'll remember that very basic definition of shock, shock is inadequate tissue perfusion. So what does that mean? Not getting enough oxygen and nutrients to the cells of the body, and because of lack of perfusion, waste products aren't being removed and begin to build up. One of those primary waste products that would build up would be carbon dioxide, which lowers the pH of the blood, resulting in acidosis. We'll talk more about acidosis later in this lecture. As I mentioned, some tissues require a constant supply of blood, while others can survive with very little for an extended period of time. We started with the brain and the heart requiring a constant supply. They survive a shorter time without a constant supply of blood. Next, the kidneys and the liver. They can survive longer, but not as long as an organ like the skin or even bone. Bone, in fact, after death, bone is viable for being harvested for transplantation, I believe, for close to 24 hours at normal temperatures. So hemorrhaging means bleeding. We are losing the red sticky stuff, which contains the hemoglobin, which is the vehicle to get blood to the body, so bad things start to happen, namely drop in pressure, lack of perfusion of organs. We lose that vehicle, the hemoglobin that transports the oxygen around to the tissues of our body. Our job is to recognize the bleeding. You say, well, that's easy. Good grief. The red sticky stuff is coming out. We just have to fix it, right? Not all bleeding is external. We can see the external bleeding, and through treatment like direct pressure or even a tourniquet, we can try to slow that flow of blood or stop that flow of blood until a physician can treat that with sutures or with surgery. We can do that. When that bleeding is internal, the best we can do is treat the patient to try to maximize the oxygenation of tissue, minimize the blood loss, and get that patient to definitive care. Your body's it adapts well. If you remember back to the shock chapter, I told you then, and I didn't make this up, it's in your book, but I told you then the body can tolerate up to about a 20% loss of total circulating volume, and it can, if you remember the word compensated shock, body can compensate through the mechanisms that we just mentioned to try to maintain homeostasis or normal functioning until that problem can be corrected. Blood volume or circulating volume, as I just mentioned, that's how much blood is in the body. You'll learn a formula later in your EMS education, but for now we're going to say 5 to 6 liters. In a couple of weeks, we'll talk about pregnancy and the expansion of total circulating volume in a pregnant woman, and we'll see that between 25 and 40% increase in circulating volume isn't uncommon, and we'll talk about the reasons for that in detail when we do the OB chapter. And we talked about what changes occur with significant blood loss, as part of that, as part of the body's reaction to that blood loss. We have increase in heart rate. That's part of the compensatory mechanism. We have an increase in respiratory rate. That's part of the compensatory mechanism. We have a decrease in blood pressure. That would be because the compensatory mechanism possibly isn't 100% effective. If you'll remember from the shock chapter, drop in blood pressure with shock, in our case today, that would be hemorrhagic shock. That is a late finding. So we are trying to avoid that drop in blood pressure by treating our patient and providing what they need to work with that compensatory mechanism to perfuse the body. Kids compensate really well for blood loss. We talked about that. Why is that? They have young, healthy bodies that are functioning closer to maximum efficiency than an old guy like me, who's too fat. I have plaque in my arteries, probably some plaque, which interferes with that vasoconstriction. You may have an adult who is on medications that interfere with compensatory mechanisms. We'll mention those briefly in a few more slides. So I could ask for a show of hands, but I can't see your hands. So, but most of us have donated blood. How much blood do we donate when we go in? It's 1 unit. Blood is not exactly measured in milliliters like most other fluids that we use in medicine. It's measured as a unit, but a unit's roughly 500 milliliters, and we usually donate that over, depends on how quickly you bleed, I guess. It's anywhere from 15 to 30 minutes. Some people it takes longer. Our body compensates for that. We barely notice any change. Sometimes when you stand for the first time after donating blood, you might get a little dizzy, you might feel a little bit faint, but for the most part, they keep you in that chair, give you some fluids to drink. They know how to help your body compensate for that loss of blood that you just suffered. And usually by the time you stand up from that chair where you donated, you don't really even notice that you've lost any blood. You start to feel thirsty, things like that, because your body needs to replace fluids, especially after a blood loss like that. But let's talk about what happens when that blood loss is faster. Let's say something like a fractured femur. Your book says that a midshaft femur fracture is counted as a rapid blood loss of 500 milliliters to 1 liter of blood. I always just go with 1 liter as a rule of thumb. Some books will even take that up to 1.5 liters. That's significant in and of itself. But if we have 6 liters of blood, and if our patient has 6 liters of blood and they suffer bilateral fractured femurs, that would be 2 liters of blood loss, and we're going to count that as rapid blood loss. Our patient has then suffered a rapid blood loss of 1/3 of their circulating volume, which is definitely significantly more than that 20%. And our patient's body may have difficulty in compensating for that blood loss, and we may see them move quickly into decompensated shock. So we have to know what to do to deal with that internal bleeding, how to minimize that blood loss, and how to hold our patient over until they can get definitive treatment, possibly even a blood transfusion. So types of bleeding, arterial bleeding, that's where we lose blood the fastest. If you roll up and your patient has a major laceration with bright red stuff squirting out in a pulsing fashion, you probably have a good idea what their pulse is if you can count the squirts. If it's that bad, hopefully it's not that bad. It's rare that you would see that significant of an arterial bleed. If the bleed is that bad, that patient may not be spurting the bright red stuff for very long. So that's arterial bleeding. And then venous bleeding is dark red. It's more of a flow. It is easier to manage. We can manage arterial bleeding, let's say if it's in an extremity, as long as it is not extremely proximal on that extremity so that it's right up at a joint. We can use a tourniquet to stop that blood flow, just like all of you did in lab. All right, so we get to see some blood. That's what you came here for today. It's what we live for, right? We can have a paper cut, horrible thing. What's worse than that? A cardboard cut. Those don't bleed a lot unless it's me, and then I consider that a significant blood loss right off the bat. It hurts, it bleeds, you hold pressure on it, it stops bleeding, everything's good. We don't run those calls. I say that. Hopefully you'll never respond to a paper cut. I don't believe I ever have. If you do, shoot me an email or a text or something. I want to know all about it. I think there are other factors at play if you respond to a paper cut. Okay. Hockey player on that bottom right, he's not going to lose 20% of his blood volume from that nosebleed or those teeth that got knocked out, but that's impressive. That's what we go to hockey games for, right there, to see that. We don't care about the score. We want to see blood and fights and all that stuff. Moving up one picture, what is that? That's an open fracture. Depending on where those sharp bone ends are and what blood vessels are near those sharp blood ends, you can have some significant bleeding from an open fracture. Those are more difficult for us to manage. Pre-hospitally, we need to get them to the hospital, and they're probably going to need an orthopedic surgeon to fix that. Clotting, how does clotting work? You have a break in the skin, immediately vessels that are lacerated or disrupted, they narrow. You have vasoconstriction right at the spot, and then a cascade starts that we'll talk about in just a minute. That works to form a clot that stops the bleeding. If clot formation fails, then bleeding won't stop, except for the old surgeon's rule. All bleeding stops eventually. So if in our perfusion triangle you run out of the fluid, then that's the end of everything, right? Unless we have somebody that can quickly replace that fluid, but there's a good chance when they run out of fluid, they have been on a downhill slide long enough that there's not much we're going to be able to do, or it just resulted in instant death, like the aortic rupture or the aortic tears that we talked about in trauma overview. That can be such a rapid blood loss that our patient almost instantly dies. They lose their complete circulating volume in a very short time. In the case of an aortic shear, and there's very little anybody can do for them at that point. Clotting cascade. This is going to be tricky because this video might not play. I'm gonna talk through it real quick in case the video doesn't play, and then what I'll do is send you a link to the YouTube video. Chances are you'll see this. You might not be able to hear it. Somebody's going to have to hit their mic and let me know whether they can hear this or not. What happens? You have an activation of what they call an extrinsic pathway. You have a laceration that results in bleeding. There's also intrinsic pathways. I'm just going to talk through the extrinsic here. You have a laceration or an injury to a vessel that causes prothrombin activation, then prothrombin activator. I'm sorry, let me start back. That releases prothrombin activator. That combines with calcium ions to produce prothrombin. Then, because of other clotting factors, prothrombin becomes thrombin. Then we have more clotting factors involved, and then we have fibrinogen, and fibrinogen, because of more clotting factors, becomes fibrin. Then you have calcium ions that allow fibrin to turn into fibrin polymers, and fibrin polymers combine with platelets to form a clot. That plugs the flow, hopefully, and at the same time, you have an inflammatory response so that you have nature's direct pressure. You have swelling in the area of that cut, and hopefully that pressure slows the flow while this whole cascade is happening to help stem the flow and stop the bleeding. In fact, I know you're not going to be able to hear the audio of this video, so I'm going to bounce on past that. But it's important to understand this clotting cascade, at least at a basic level, for purposes of bleeding that we're talking about today and injuries to the body, but it will also help you in understanding what happens in a myocardial infarction when you have rupture of plaque, and that causes bleeding in a small area in a coronary artery, and how that eventually results in the occlusion of that coronary artery, which results in death of tissue being perfused by that. So it's a good idea to watch this video, and I'll throw a link to it up to it on Blackboard so that you can watch it. We're not talking a long video. I think it's like 2.5, 3 minutes, maybe 4, but it'll be a good use of your time. It explains it much better than me. And the person has a cool accent. They don't have a West Texas accent like me. They have this real slick, cool accent that you'll enjoy. Okay, let's move on before we take a break and talk about trauma's lethal triad. And you talked about this, you learned about this when you were doing the lecture part of trauma assessment, and we were stressing the importance of ventilating your patient and keeping your patient warm, which means that you keep yourself uncomfortable, and how important it is to spot that life-threatening bleeding, jump on that, stop that bleeding with direct pressure or a tourniquet, and try to maintain our patients so that we deliver them maybe as warm, peak, and dry as possible. I guess we'll leave it at that. this lethal triad of hypothermia, acidosis, and coagulopathy, a lot of brand new paramedics, or maybe some egotistical old paramedics, would say EMTs can't treat this because you can't start IVs. And then at the hotshot services, the ground ambulances now that carry blood products, they have whole blood or uh, packed red blood cells, those types of things that they can infuse into a trauma patient, and they can intubate. They have all these cool tools. That's the fun part of being a paramedic. But without good BLS, not a bit of that matters. And you can do everything at a BLS level that it takes to help start to stabilize that patient so that the ALS treatments matter. How do we deal with hypothermia? Oh man, we in summer in Houston, Texas, I would say it's August in Houston, Texas. It's not fit for humans down there. Under air conditioning, you don't want to go to Houston, Texas in August. But I would tell you that if you have a major trauma patient in Houston, Texas in August, that patient needs to be under blankets. You need to turn the heater, yes, the heater on, crank it up so that you're pouring sweat. Your goal when you open the back doors of that ambulance at the trauma center to get out, you want to look like you just climbed out of a swimming pool, because that's what your patient needs. We want to keep that patient's core body temperature as close to the norm of 37 degrees Celsius as possible. Acidosis, how in the heck do we deal with that? We can't start IVs and push medications into these patients. So we're EMTs. We can't do anything about that. Oh no, you're extremely wrong there. We have this cool little tool called a bag valve mask, and we can ventilate our patients. We can get that with 100% O2, provide that maximum amount of O2 possible down into those alveoli so that that magic gas exchange can take place down there and provide the maximum oxygen possible to our trauma patients. And by controlling that rate and depth of their respirations, we're also moving that carbon dioxide out. Acidosis comes from having too many hydrogen ions present in tissues. And so if we're moving CO2 out, and oxygen in, we are decreasing that concentration of hydrogen ions. That's what pH stands for. So I have their acidosis is pH of less than 7.35. So the higher the hydrogen ion concentration, the lower the pH. So if we're ventilating that patient properly and respiration, remember that, is taking place, we're moving that CO2 out so that that pH stays higher. And so as EMTs, we can have a major impact on that. Then finally, we have coagulopathy. We just talked about proper coagulation. So remember, pathy is disorder or disease, is what that suffix is. So coagulopathy would be screwed up coagulation, right? That's easy. That's a good old West Texas kind of definition, but that might help you remember it. Coagulopathy is screwed up coagulation. What can we do about that? Look back up there right above that at hypothermia. One thing we can do is keep those patients warm. If the patient is warm, that helps them coagulate. That helps that coagulation cascade work properly, and that stems the flow of the red stuff coming out of the whatever hole that has opened up that's caused the leak or the squirt. Acidosis also interferes with coagulation. So that triad right there, it all works together. If we do not do anything to help manage this triad, patients' hemorrhage worsens. They bleed more and more and more. Compensatory mechanisms eventually start to fail, and our patient dies. Now, why in the world am I backing up to hypothermia? Why in the world do I want the heater on in Houston, Texas? Even mild hypothermia, as I put in this bullet point right here, even mild hypothermia in your trauma patient can result in devastating failure of coagulation cascade and have horrible physiologic consequences. Man, those are big $2 words. It just means massive damage to the body, right? Physiology is the functioning of the human body. Pathophysiology would be poor function of the human body or diseased function, injured function of the human body. So the pathophysiology of trauma is that these things that we've just listed, hypothermia, acidosis, coagulopathy, result in that disease of trauma that in the end can kill our patient. Okay. Also, this is just common sense. You didn't have to come to EMT class to learn this. Another way that coagulopathy is taking place in our patients who have bleeding, they're losing clotting factors. They're losing platelets. They're losing the things needed to form blood clots and stop bleeding. So we need another way that we deal with coagulopathy as EMTs, direct pressure, tourniquets, the things we need to stop bleeding, or internal bleeding, back to gasoline or diesel therapy with the delivery device being the skinny pedal on the right. We need to get them to a trauma center or jet fuel. We can call for a helicopter to come out, get these patients into the hospital quicker, so that the ER doc can start infusing some blood, and in the end, probably a surgeon is going to get in and repair the damage. We're an important part of that. And we've already talked some about the management here. Keep looking for the source of the bleeding. If we can identify blunt force trauma to the right upper quadrant, and you have distension of the right upper quadrant of the abdomen, you have discoloration, and you have hypotension, you have identified one of with a degree of certainty what one of the major sources of the bleeding is, and you can notify that receiving facility so they have the right players in place to deal with your patient's injury when you get there. They're not going to call a neurosurgeon for that. They're going to call a trauma surgeon or a general surgeon who can get in there and repair that liver. So hopefully repair that liver. All right. Next major heading, strip them and flip them. What in the heck? If you can't see it, you can't treat it. So we got to strip them so we can see that discoloration. We can see through our physical examination, through Again, how do we do that? Inspection, auscultation, and palpation. Unless we have a hemothorax and we have bleeding in the chest, auscultation isn't a major player in this portion of our exam. So inspection and palpation are our major tools in dealing with this. Flip them, we're not going to flip them head over heels down the road and as part of this examination. That just sounds horribly ridiculous. We are going to roll them, log roll them, maintaining spinal immobilization in a trauma patient where there's an indication that there might be spinal trauma, so we can inspect and palpate the posterior side of our patient. So that's extremely important. So strip them and flip them. We've got to keep them hot. We're going to limit exposure to the environment. We're not going to strip them out on right beside an interstate highway in a blizzard in February in Denver, Colorado. We're going to get them in the back of our ambulance as quickly as possible, crank the heat up, and we're going to log roll them and inspect that back. We're also going to get the wet clothing off of them. Sometimes that's just blood-soaked wet clothing that we have to get out of the way. And put a nice blanket on the backboard and roll your patient onto that blanket so that we don't lose heat down to that board. We need a blanket there also. That's something that a lot of people don't think about, and you don't always see EMTs and medics do that in the field, and that's sad because that is very important. It's something really easy to do. Crank up the heat in the ambulance again. Like I already said, get those wet, bloody, sticky clothes out of the way. Another thing about having a cold patient, they start to shiver. That burns up energy, that wastes oxygen in the energy necessary for those muscles to contract and relax to try to generate heat. And through that work of the muscles, also produce more lactate, which is the acid that contributes to lactic acidosis. So as you can see, there are a lot of things as EMTs that we can do. I'm spending a lot of time here because this is really important. Monitor and maximize oxygen. If our patient is shocky and their body is compensating for that shock through massive peripheral vasoconstriction, your SpO2 monitor on their finger is probably not going to work worth a flip. So how are we going to monitor oxygenation? Skin color. Check the skin color. And if you have as you progress in your EMS career, you can also use waveform capnography, and that's an even better indication of perfusion than an SpO2 monitor is, period. So you'll learn to engage that tool. It is something registry wants us to talk about now. After I have the illustrator, I can show you some more things about waveform capnography and monitoring the exhale CO2 as an indication of how your patient's doing. All right. Hemophilia, that is a disorder with clotting factors that interferes with that clotting cascade, and even small injuries they won't clot, and the body isn't able to stop that bleeding, and the patient just continues to bleed and bleed. It's a rare disorder. It's much more prevalent in males than females. Females are usually carriers. I guess we won't go down into the genetics of that, but females are carriers. Logically, it makes sense if a female is a hemophiliac and reaches puberty and begins menstruating each month, that menstrual flow is going to potentially cause hypovolemia every month, except for there may not be subsequent months. So that makes sense to me. Those patients require rapid transport. How are we going to know that our patient's a hemophiliac? Hopefully there's going to be a family member or the patient to tell us that as we're getting a sample history, or if we have an unconscious patient, it may be that we're looking at a medical alert bracelet or necklace to get that information. Let's take a break here at internal bleeding, and then we'll come back and knock this on out, and we'll move on to soft tissue injuries. All right, let's take 5 here. I'll see you in 5 minutes. Okay, next is a difficult principle. I think you guys can all handle it. If bleeding isn't external, it's internal. So now we'll move on to internal bleeding. That sounded funny in my head. It was not good when I said it. Okay, what is that? That's bleeding on the inside. There's not a hole from the outside through to the inside that caused the bleeding. So we talked about blunt force trauma the other day in trauma overview. That could be one cause of internal bleeding. Closed fractures could be another cause of internal bleeding. And then just other bleeding, internal bleeding. Let's think about things such as an ulcer that's bleeding. Maybe our patient has colon cancer, and that colon cancer is starting to cause bleeding, and maybe they don't even. Maybe it's a slow bleed. It's not something that they notice right away. They start to feel weak because they're anemic. Anemia. They're lacking red blood cells. They're bleeding out. They feel tired. They feel draggy, and then go in to see the doc, and the doc figures out what's going on. But the big internal bleeding that we're talking about right now, and that we think about in EMS, is some sort of massive injury or damage to internal organs that results in extensive internal bleeding, eventually causing hypovolemic shock, then irreversible shock and killing our patients. If you'll remember, irreversible shock is simply enough damage to individual organs that you start to have multiple organ failure. So our patient starts to have liver failure, kidney failure, and eventually heart failure, and then our patient dies. So that's the basics of irreversible shock. You may remember that from that chapter about 2 months ago now, I think. Okay. Causes: stomach ulcer, lacerated liver, ruptured spleen, broken bones, especially ribs and lower ribs, the inferior ribs down there if you can picture that skeleton in the classroom and you think about the costal arch where the floating ribs are, when you get down that low in the rib cage, that's the part of the rib cage that covers, or doesn't cover, well, it does. It helps protect the liver and helps protect the spleen. And fractures of those ribs can be just like a large sharp knife stabbing into one of those two structures and can cause massive bleeding. Then pelvic fractures, we have very large vessels. We have there, and we have our iliac artery, iliac vein on each side coming through there. Those are very large vessels, and that can result in extensive bleeding. Adult pelvis could even hold maybe 2 to 3 liters of blood. So that's, I mean, we're pushing half the circulating volume there in that pelvis. That's why it's important to stabilize pelvic fractures. Talk more about that next week, maybe. Okay, mechanism of injury. We spent all day long on mechanisms of injury on Tuesday. What do mechanisms of injury, why is that important to us? That increases our index of suspicion of serious and even unseen injury, and the unseen injuries. So when we have massive forces applied to the body, such as in motor vehicle collisions or in stabbings and shootings, those are major forces. Those are significant mechanisms of injury applied to the body that in the end can have catastrophic results. One of the things that comes to mind with massive forces from high energy MOI, I think about a rapid deceleration injury that results in a extensive laceration of the liver and patient who bleeds out quickly. I have a picture in a minute I'll show you of one of those. And how do we find these? Our good old friend, that acronym DCAT BTLS, deformity, crepitus or contusions, abrasions, punctures and penetrations, burns, tenderness, lacerations, and swelling. And we do that systematic head-to-toe physical exam of our patient, including their back. So we're going to inspect the posterior side, and we're going to apply DCAT BTLS over and over and over and over all the way down, looking for abnormalities in these 8 things that give rise to our index of suspicion of the injuries to our patient resulting in this internal bleeding. It's our job to normally say we find it, we fix it, we move on. This is a life threat. We find and we try to stabilize our patient for rapid transport after minimizing on-scene time. Okay, liver is by far the most commonly injured abdominal organ, and the liver it's a massive organ. It has a rich blood supply to it. It is a major filter of blood, and if we have tears / lacerations to the liver, massive bleeding can occur. This falciform ligament right here, I mentioned Tuesday in class that there was a ligament that helped hold the liver in place, that acted just like a big sword or a bandsaw that cuts through the liver during a rapid deceleration injury. And let me show you what that looks like. That is a lacerated liver, and as you could imagine, that resulted in massive catastrophic bleeding. And this patient, I believe that this patient is Dead. This is an autopsy picture, I believe, due to the color of the liver and then how gray that lung is up there. So I think that is a dead patient. It's the largest organ in the abdominal cavity, and one of the most common injured organs in all patients with abdominal trauma. And it, because of the size of the liver and the fact that it covers probably a good 40% or more of the right upper quadrant, and then extends over partially into the left upper quadrant. If we have penetrating trauma to the abdomen, there is a high likelihood that unless it's really a far isolated far left lateral injury, we're going to be dealing with possibly a traumatic bleeding to the liver. So, okay. Remember nature of illness in OI. We mentioned some of the ways that can cause internal bleeding, ulcers, bleeding from the colon, unless there's penetrating trauma or there's massive damage to the colon, such as in a primary blast injury, where that blast wave can possibly even cause a rupture of the colon because it is a hollow organ. We don't normally think of it that way, but it is. It is a hollow organ, and that primary blast injury can rupture the colon and cause massive bleeding. We're talking nature of illness here. We're not talking trauma. So we're talking a slow bleed that would be possibly from something like colon cancer. Blood that isn't obvious, this blood would be in the stool that's eliminated by the patient. It's found with a guaiac test. We don't do those. There's a potential that you could do a guaiac test if you worked in an ER or a doctor's office. There's a chance, but normally it's definitely not a pre-hospital thing. Okay. Ruptured ectopic pregnancies, those are major causes of internal bleeding and death in pregnant women. And then aortic aneurysms, an abdominal aortic aneurysm, you could possibly have that sudden onset of that tearing abdominal pain, can even have a pulsating mass in the abdomen, and if that thing starts to leak blood, you can see Cullen sign or Gray Turner sign, and that is ecchymosis or a bruising appearance either around the umbilicus or on the flank of the patient. Try to picture that, try to visualize that. Oh, there you go. You can visualize that. Cullen sign, peri around the umbilicus, periumbilical ecchymosis. That is that bruising. It's hard to tell what this is over here for Gray Turner. That is Gray Turner. That is the flank of the patient. So these are probably, maybe boxer shorts or pajama pants. Oh, that would be a butt crack there. It would be the landmark. That's flank. That's that ecchymosis around the flank. That's a late sign. If we have a patient with maybe they have a lacerated liver, they've suffered some sort of trauma that causes bleeding in the abdomen. When we read our textbook, it leads us to believe that, oh man, they have internal bleeding. We're going to find that Cullen sign or that Gray Turner sign. But that's a late sign that shows up after the patient has been bleeding for a while. Guaiac test, using a gloved hand preferably, take a finger and get some fecal material on it. You rub it on, this is a little card. You rub it on the card. You see that on the left. You don't see that. You don't see that they rub poop on there, but you take some of that fecal material, smear it on that guaiac card, and if there's blood present in that stool, you get a reaction, reacting to the, I believe it reacts to the iron in the blood, and you see that change in color. That's not important. It is important. It's I don't know. Your book mentioned it, so I thought I'd find a picture and throw in there. Okay, signs and symptoms of internal bleeding. Pain. Yes, there's going to be pain. Swelling in the bleeding area. For instance, with the liver, you start to see abdominal distension, and then dyspnea, tachycardia, and finally hypotension. Those would be the first two signs of compensation of that compensatory mechanism in compensated shock, and then later hypotension develops. In kids, like pediatric trauma, kids' bodies are great at compensating. And I started to talk about this earlier, and my train ran off the tracks. And I got derailed there, but kids compensate, and then it's like they just fell off of a hemodynamic cliff. They've compensated all they can. Compensatory mechanisms fail, and they just die right in front of you. Whereas adults, they're more, the progression more follows compensation, and then a downhill slide to the point of going into cardiac arrest. But man, kids just, I mean, they go downhill in a hurry right in front of you. So your key things with kids who have suffered trauma and potentially have internal bleeding, or even if they have external bleeding, is we need to get them to definitive care as quickly as possible, because we don't want to be there when they fall off that cliff. And they're at the hospital, they have far more tools to deal with that than anybody in EMS does. Hematoma, and then bruising. So a hematoma would be like that goose egg on the head. When somebody gets bonked in the forehead, you have that localized swelling that pops up, and then that discolors and starts to bruise, and then possibly have bleeding from an opening in the body. Signs and symptoms of internal bleeding: hematemesis, throwing up blood. Then melena, that is going to be digested blood. That's the black tarry stuff in the stool. Pain, tenderness, bruising, guarding, or swelling. Fractured ribs down in that lower part of the rib cage that can act just like a knife shredding those tissues of the liver or the spleen. Signs of hypoperfusion. Let's remember some of those. One of the early ones is going to be confusion or agitation that just seems totally inappropriate, followed by a decreasing level of consciousness, and then unconsciousness. Those are signs of hypoperfusion, as are cyanosis and like gray color of the skin that in the periphery, eventually making its way into the core of the person. Scene safety, scene size up, scene safety. Is there anything there that will injure or kill me? Is there anything in that scene that's going to injure or kill my partner? We don't enter unless we have a safe, stable scene to enter. Then we have to quickly determine that mechanism of injury to our patient. or nature of illness. Consider spinal immobilization where proper. Do we need additional resources? What would those be? Do we need to call for fire department to come give us extra hands during transport? Do we walk into what we think is a medical call, find out we have our patient has been the victim of some sort of violence, and possibly the inflictor of the violence could still be around to the point that we have to withdraw and call for police to come help us. Other additional resources, possibly calling for a helicopter. We talked about calling the helicopter on Tuesday. Don't be distracted from life threats. When we do soft tissue injuries here in a few minutes, going to see some cool pictures of horribly injured people, and they have horrible injuries that aren't life-threatening injuries. Don't let those things be distracting injuries away from, let's say, that lacerated spleen causing that distension in the left upper quadrant. And oh man, we also have distension in the right upper quadrant. We have rigidity to both upper quadrants of the abdomen, and we need to be at the hospital right now. General impression, sick, not sick, critical, non-critical, just from our initial size up. Get that rapid exam done. We need to work through the ABCs. And remember, when we did that trauma assessment algorithm, we put X above ABCDE. What does that stand for? Exsanguination. And that's to remind us that we need to deal with our patient who has massive external bleeding. We need to deal with that before we move on to ABCs. And the X came from pre-hospital trauma life support course. Last year in the new book, they added that X above ABCs. So we started teaching it to you guys. So you'll be advanced before you even get to that class. And we need to assess skin color onto that level of consciousness. What did we teach you? Walk up, look the patient right in the eyes, grab bilateral radial pulses to see if they're present, look them in the eyes, and say, what happened? Or, buddy, I'm a paramedic. Can you tell me what happened to you? Something that they can't answer with one word, so that they have to respond to what you said, so that you get an idea of where they are on this AVPU scale. You need to take care of that airway. You guys know how to do that. Don't withhold oxygen from these trauma patients. We're not going to start with a nasal cannula. We're going to immediately get high flow oxygen on these patients. And if their rate and depth of their respirations aren't sufficient, or if they have one of the breathing patterns that we'll talk about here in a couple of weeks that you can find with trauma patients, then we need to be bag assisting their breathing, or if they're not breathing at all, of course, you know to bag them. You learned that, you knew it probably before you got here, but you knew we perfected your use of those tools the second and third class periods of this course when we did CPR. Be sure to use an airway adjunct if your patient is unconscious. My go-to is an oropharyngeal airway. Try that OPA. If they have a gag reflex, then we need to get that thing the heck out of there. And then if they don't have facial trauma and we don't suspect that they have a basilar skull fracture, we can go ahead and get that nasopharyngeal airway in place. And your patients are going to tolerate those pretty well. Lube them up with some KY, slide those baby right in there. Circulation, you know how to assess it. And we just assessed that, right? When we grabbed those bilateral radial pulses and we looked them right in the eyes, we could determine a lot. Did their skin feel sweaty? Did they have a rapid, thready pulse, at both of those radial pulses, man, I'm thinking in a trauma patient, I grab those bilateral radial pulses, I feel diaphoretic skin, and I feel a weak, thready pulse. I have a patient who is shocky, and I've got to get moving. I'm looking them right in the eyes and asking them questions, and we determine where they are on that ABPU scale, of course, but I'm also looking at that skin color. Do they have cyanosis around their lips? What is their skin color? Do they have that gray ashen skin color, or do you have pink color? Are they cool to the touch? So when we grab those bilateral radial pulses, were they cool and clammy? Those are important signs of their circulatory status. So we're assessing circulation from the get-go here. We find that external bleeding. Remember, in our primary assessment, we find a life threat, we find it, fix it, and we don't move on until we have fixed it. So, and then we treat for shock, and we spend a lot of time going through that that lethal triad, so you know exactly what to do there. And then are they tachycardic, tachypneic? Those are going to be indications of compensated shock. What's their blood pressure? What's the nature and quality of their pulse? Do they have clammy skin? Just like we said, investigate and then we decat BTLS them head to toe, front and back, so anterior and posterior, and then whatever their chief complaint is or whatever their most serious injury is, we're going to investigate that chief complaint. And sample history, yes, it's always there. We're not going to stay on scene and get an extensive sample history like we would with the medical patient or with a cardiac patient. We're just not going to stay there and jack around. We're going to get important things if we can from the patient or from a medical alert bracelet, medical alert necklace, bystanders, things that we need to find out about if possible. What medications are they taking? Maybe our patient has atrial fibrillation and they're on blood thinners to try to keep them from having a stroke or having a pulmonary embolism because of what the sludging of blood that atrial fibrillation causes in the atria. They anticoagulate those patients. That becomes a problem, right? If we're anticoagulating them, we're interfering with that clotting cascade, so we keep the body from forming clots as easily, and then all of a sudden we need to form a clot and we can't. Our patient has a major problem. Beta blockers. When we talked about compensated shock, and we talked about that autonomic nervous system action based on adrenaline hitting those beta receptors and alpha receptors. Beta receptors, if they're on beta blockers, that's going to interfere with the body's ability to increase the heart rate and interfere with the ability to increase the contractility of that heart muscle. So those patients aren't going to compensate for shock well. They're going to go they're going to decompensate, and they're going to die in a hurry if we don't get them some help. If your patient's on blood thinners and beta blockers, they've suffered trauma, call for an ALS unit quickly. If you have a long transport, you could call for a helicopter as an ALS unit. You could have an ALS unit rendezvous with you on the way to the hospital so that they can give medications to that patient to help counter the effects of the beta blockers. So, if your patient's unresponsive, do the best you can to get a history, but don't waste time doing it. Get a good set of baseline vitals right off the bat, and then we're going to trend vital signs. We want to know, is that heart rate getting faster? Is the respiratory rate getting faster? Oh, holy smokes, now they're becoming hypotensive. Our compensatory mechanism is starting to fail, and they've started that slide down the scale of decompensated shock. So when we reassess, we're going to get a good set of vital signs, record those every 5 minutes in a critical patient so that we can trend those vital signs and we can see what's happening with our patients. We're not going to waste time on scene doing the secondary assessment with these patients. We're going to do that secondary assessment. Just picture in your mind that patient assessment algorithm. And we're going to do all of those things in all likelihood while we're bouncing down the road. That would include some of our treatment. Okay. That systematic, we're going to do that rapid trauma up there with our primary survey. That's where we start at C7, go over the top of the head. We stop and look at the pupils. If our patient, if their brain isn't being perfused well, if we check their pupils, they're going to be sluggish. They don't respond quickly. That is a major finding when you find that. Hypoxia does that to the brain, and that causes the pupils to be sluggish, to constrict when we shine our pin light in their eyes. That's a major finding that you need to note, and you need to know right then that you have a critical patient. Then we're going to move down, look to see if the trachea is midline, look for jugular venous distension. Then we're going to look at the rise and fall of the chest. We're going to palpate the chest, look for symmetric chest rise and fall. Then we're going to palpate all 4 quadrants of the abdomen, comparing one side to the other, checking for rigidity, checking for tenderness, looking for discoloration. Then we're going to check the stability of the pelvis. Then we're going to do our alligator mouth down the femurs. Why do I say alligator mouth? Put one hand on the bottom, one hand on the top, and quickly go down that femur, feeling for any major deformity. At the same time, you check your gloves when you move along to see if you have blood all over them. We'll do both femurs. Then we're going to come up and through that we're going to identify problems that can give us a high index of suspicion of internal bleeding, and then we're going to make our treatment decision. Accordingly, our treatment decision may be that we've got to scoot. We're not applying DCAT BTLS when we go through that rapid trauma. That rapid trauma, you better be able to do that in 30 to 45 seconds. And you'll get there. I don't expect that you're that fast at it now, although you might be. But you will pick up speed with experience, and with experience comes a comfort level in applying that systematic approach. This secondary assessment, head to toe, full exam, DCAT BTLS, applying that to our patient from head to toe, remember including the back. Reassess every 5 minutes, an unstable patient or / critical patient every 15 with the stable patient. You don't have to wait 15. We say that all the time. 10 minutes, if you can reassess them every 10 minutes, that's great. And then we're going to communicate our findings to the receiving hospital. Call that trauma alert early on if you have a critical patient. And then we're going to, as we hand off our patient, remember we always hand off to someone who is equal level of training or higher than us. Otherwise, it's abandonment. That's back to the medical legal chapter. So as EMTs, we're not going to report off to the custodial staff in a small hospital when everybody else is busy. We have to report off to an EMT, LVN/LPN, depending on what state you're in, RN, or even a physician. And then included in there would be PAs and nurse practitioners. And then when we write our patient care report, we're going to document all injuries, we're document all findings, and patient's response to any interventions. Always maintain standard precautions. Use your PPE. Wow, up until 6 weeks ago, I joked all the time and said, we don't wear gowns in EMS. You'll have your gloves and your eye protection, maybe a mask. We don't wear gowns in EMS. Oh yeah, we wear gowns in EMS all the time now. So get our pretty yellow paper gown or a Tyvek gown, whatever we have. Not many Tyvek gowns out there. Anyway, standard precautions. Wet and sticky and it ain't yours. Protect yourself from it. All right. That's also known as body substance isolation, BSI. In some of the videos we watched in our labs, we heard them talk about BSI. That's the same thing. That's PPE. Wearing our PPE to protect us from body fluids is BSI. Provide that high flow oxygen. Don't start writing your PCR bouncing down the road because you want to hurry and get back in service because you have to get back to a TV to watch American Idol at the station because your significant other's coming to the station and bringing dinner to watch American Idol with you. You observe and treat your patient while you're transporting. You do paperwork/digital paperwork when you get to the hospital. Don't take your focus off that patient to focus on something else. You can't do two things at once and do them well. Okay, direct pressure. Direct pressure, we know how to apply direct pressure to stop external bleeding. Pressure dressing, we take an elastic bandage and wrap around without cutting off the distal pulse, using that roller bandage to cover that wound, to hold that dressing in place. It puts pressure down on that dressing to help stop bleeding. We don't remove those till a physician has evaluated the patient. Part of assessing that intervention is always rechecking distal pulse where that pressure dressing is every time that we reassess our patient. Well, why would we do that? We mentioned the inflammatory response or the swelling that goes with having a laceration to the body or having an injury to the body. As that swelling progresses, what was once a snug pressure dressing has now become an extremely tight pressure dressing that cuts off circulation. So we have to make sure that we're assessing those. And we can loosen that. We're not going to remove it. But if we lose a pulse and we lose capillary refill in that extremity where that pressure dressing is, we have to loosen it. Hemostatic agents, the hemostatic impregnated gauze, the gel, that helps with clotting. Use that in conjunction with a pressure dressing. They've really gotten away from that gel and that injectable stuff because it just forms cement. Kind of feels like cement in there. And there's also a chance of introducing some of that stuff into circulation, causing our patient to have a pulmonary embolism or a stroke. So the combat gauze, the hemostatic gauze is our go-to most places, depending on your protocol. And then a tourniquet. We know how to use a tourniquet. We know we use a tourniquet as our most invasive means of stopping external bleeding in an extremity. Our goal is to stop distal circulation from that. So we position that tourniquet above the injury. Commercial tourniquets are readily available out there. You practice with a couple of different kinds in lab. Know what equipment's on your ambulance or in your jump bag, say if you were at a fire department. Know how to use those suckers. Don't be figuring out how to use equipment when you're in the process of using that as an intervention with a critical patient. And then the old Boy Scout way of a triangular bandage and using a stick or some sort of rod to twist that down. Remember, we write TK with a Sharpie on our patient's forehead and the time that we put it on and our initials. Was there another option in this treatment? It doesn't look like. Somebody lost both their legs, massive bleeding, 2 tourniquets to stop that bleeding. All right. Never cover a tourniquet with a bandage. We did all this in lab, so I'm not going to read through all of these. Don't use anything that's going to cut down through the skin, like wire, rope, a narrow belt, anything like that. I need something that's more broad, that's going to hold pressure and squeeze down in to stop that tourniquet, that bleeding. And once we put it on, we don't loosen it, we don't take it off, we don't pad under a tourniquet. I almost missed that one. Air splints, how does that control bleeding? Stabilizes a fracture, so those knives, otherwise known as bone ends, down there in that where that fracture aren't just shredding up tissue, lacerating vessels. Vessels meaning arteries and veins, and then the smaller vascular structures. Rigid splints, same thing, we just stabilize it. Air splints could be used as a pressure dressing. Bleeding from nose, ears, mouth, caused by skull fractures, could be caused from facial injuries. Even sinusitis infections can cause some blood, but we're not going to see a lot of blood flow from those. High blood pressure could, some sort of coagulopathy. And then digital trauma, what's that? Mining for gold. That's this number, seeing how many knuckles, how deep you can go with the finger up the nose. It's amazing how far some people can go and how much they bleed afterward. Epistaxis is a nosebleed. Occasionally you could lose enough blood to cause shock. That would be rare. Treat it by pinching the nostrils together, have the patient lean forward, put ice on the back of your patient's neck, can even have them pinch between their eyes right here, and sometimes that's a pressure point that can help deal with nosebleed. If your patient has trauma to the head and they may have a skull fracture and have blood coming out of the ears and or the nose, we don't attempt to stop that flow. We'll talk more about this when we do the head trauma chapter. Do the old halo test to see if that blood has cerebrospinal fluid in it. And we're just trying to keep it from, kind of let it flow loosely out of there and not back that flow up and increase intracranial pressure. Okay, internal bleeding usually requires surgery. We talked about that. We know how to treat shock. We put our patient in a supine position, high flow oxygen. We manage that lethal triad of trauma, just like we talked about earlier, right? Okay, anybody have questions about that? That is going to close out this session. So remember to log in to the next session to do the first half of soft tissue, and then we'll log out of that one when we get to burns, and then burns will be the third session. So we'll close this session. I'll stop the recording. We'll close this session. I'll see you back in 10 minutes, and we will start that next session. So stretch your legs, get some oxygen to your gluteus maximus and lower extremities, and we'll come back and hit the next session. Thank you.